Hey everyone, how's it going? Good afternoon, Nicole. Hey, Alyssa. Good to have you guys. Ladies here with me again. Andrea. Jackson, how's it going? Good afternoon, Kelly. I'm just looking up some things just to make sure I am on the right page when I talk about them today. Mr. Krabs meme, day 3. Give it up for day 3, yeah, right? Day 3 of 4. Do I round out your whole week here when we talk tomorrow? Do you have something after me? Let's see. Our last lecture tomorrow. Wow. Pretty. What a way to end your week. Not with a bang, but a whimper, as they say. Does feel a little bit like deja vu, I'll say that. Oh, am I 2:30 tomorrow? Oh my goodness, it's so late. Yep, what do you know? 2:30, 4:30. Even gave me the very last slot, too. Just make sure to tell Professor Gurky if he goes over even a few minutes, I will be quite irate. Not really, I don't care. It'll be fine. Do you guys know what a pirate's favorite letter is? By any chance? Everyone always thinks it's R. Some people think it's the C, but honestly it's P. Because without the P, they'd be quite irate. There you go. I'm glad I got hopefully enrich your joking lives a little bit. All right, it's 12:30. Let's see here. All right, so I don't see any questions up on the board, so we can go ahead and get started. I know it probably caused a few bits of cardiac arrest out there with that bad joke, so we'll see if we can bring you back with the medications we're going to be using today. We'll see how far we get. Okay, so anyway, we are talking about the ER medications. I believe I posted that up, so if you don't see it, let me know, and I can probably click the button I forgot to click. But regardless, here we are getting into talking about intubation. I'm sure some of you have some experience with this, being maybe like in the EMS sort of realm, or perhaps if you're scribing in the ER and places like that. So talk about RSI, or rapid sequence intubation first, because this is pretty medication heavy in terms of what we're giving, how we're giving it, timing of things like that are really important. So we'll talk about that. Again, this is a rapid process to establish a secure airway for these patients here. And so there's kind of 3 steps to it. There's the prep step, which is going to be for certain special situations your patient may be coming in with. So someone who comes in and is, say, from a trauma, they're in a motor vehicle collision, versus someone who's coming in for, intractable seizures versus, drug overdose. So we'll look at some things we may need to do from the preparatory side of things. Certainly I can kind of speak a little bit to sort of the other things going on in terms of like oxygenation and all of that, but I'll, mainly be focusing on the meds. Then we'll talk about the sedation drugs that we're giving, and then paralysis. And so that'll be kind of the biggest set of new drugs that we haven't really talked about so far. Obviously, you want to do sedation before the paralysis because what you're going to find with our paralytic drugs is that they do not do anything in terms of sensation. So you could paralyze somebody and be breathing for them, but they will experience every single sensation there, and that can be pretty terrifying to think about. So we always want to make sure we have them nice and sedated, because if they're in pain or if they are experiencing something uncomfortable, they wouldn't be able to tell us because they're paralyzed and all their skeletal muscle is ineffective right now. And again, the whole point is to try to facilitate that safe and emergent tracheal intubation. This is something that should be done within a few minutes, but you'll certainly find some cases that are more difficult than that, which may be pretty challenging, and we'll talk about those in just a little bit. So before any meds get pushed here, it's really important to make sure you have your history down. So this can be a challenge, especially when patients are coming in needing to be emergently intubated, finding out things like their history of allergies or what medications they're taking or any history of things like neuromuscular disease. That'll be important for one specific drug I'll talk about, especially like small children. They may not even have had the diagnosis yet. Things like, family history of malignant hyperthermia, something we talked about before with our inhaled anesthetics. That'll come again with one med we're going to talk about here. History of asthma, previous issues with anesthesia, intubations, things like that. You may not be able to get a ton of history. So if you can, always try to do so. Talk to family members who may be there. EMS is like super critical to talk to in those really kind of emergent situations, because oftentimes those people need to get back out and go to the next call if it's particularly busy, and they may not have a whole lot of time to stick around. So if you as the provider don't get a chance to ask them questions, they may be gone. You may not be able to get a hold of them. And so we'd run into that quite often with things like, tox cases where EMS would come in, drop them off, and they're busy. They got to go to the next call. And then we couldn't get a chance to ask them like, okay, well, what did the scene look like? Were there, other people affected? What type of medication did you notice in the area? Things like that, which can be really critical in terms of getting your good history there. In terms of pre-treatment, this will be our first step and is not going to be done for everyone, but certainly when we see that we are, undergoing laryngoscopy, there are certain physiologic responses that you're going to see. There can be some sort of variable effects in terms of heart rate, but you can see some vageling down in terms of like things like bradycardia can be occurring here. You can see increases in things like intracranial pressure, blood pressure, airway resistance, so some bronchospasm that can happen there. So some of our medication are used in order to try and help prevent some of these changes in the case of things like, your patient came in after hitting their head on a steering wheel after being in a car accident, so their ICP may be elevated. You don't want to cause that to go up any further and risk, things like, herniation or something. So the first drug we'll talk about here is, and I'm kind of showing pictures of the boxes of stuff. These are typically like the boxes you're going to run into for like crash carts. If you're not familiar with the crash cart, that is usually every hospital will have these, usually on the floors in the ER in the ORs. These are things if you have a patient who's in like cardiac arrest or who is heading in that direction, needs to be intubated. These are the meds you're going to find most commonly. So these pictures here just so you can kind of familiarize yourself a little bit with them. Not that I'm going to put like a blanked out box on the test and be like, what is this? That would be ridiculous. But anyway, the first drug we're going to hit here is going to be lidocaine. You don't need to know the dosing. I'm just kind of placing it there just for, just to get you sort of familiar with it and you've seen it before. And we do this about 2 minutes prior to the intubation. And this is normally during the time when patients being sort of pre-oxygenated and all of that. And the reason why we do this is if we suspect someone has an increased ICP, right? So an intracranial pressure is elevated, especially if they have like traumatic brain injury and things like that. We do this to try to help blunt that. One of the things you're going to see is that when you have the gag reflex being activated by sticking a bunch of tubes in bleeds down the back of the throat, you can find that they can cause the gag reflex to be activated, and that can cause them to sort of vagal down, which can lead to that increase in ICP. So by giving lidocaine intravenously, you can sort of numb some of that tissue there and prevent it from being quite so sensitive. So this is one case where we might use lidocaine for pre-treatment as opposed to using it as like an or as an antiarrhythmic drug like you would normally see with IV administration there. But again, as I mentioned, it'll blunt that transient increase in ICP by trying to kind of stop that cough and gag reflex that can happen there. And again, also if causing the gag reflex, you can potentially see some vomiting, so this can also potentially help out with that as well, although it's mainly used only in patients that are suspected to have an increased intracranial pressure. The next drug we're going to be using here is atropine. Atropine is a pure muscarinic antagonist, so it's going to be blocking acetylcholine from being able to interact with muscarinic receptors. And so we know that one place we do see quite a few muscarinic receptors is on the heart. Normally, acetylcholine can cause the heart rate to slow down. This is going to do the opposite of that by blocking it. And so basically we could do this if we have someone who is bradycardic, because we know that laryngoscopy can cause them to vagal down. So if we can give this to them, if they're already bradycardic, and try to pick up that heart rate, this can prevent that from being worsened. So that's really good from that standpoint. Another case where you might see patients developing bradycardia could be as a result of repeated doses of succinylcholine. Usually it gets abbreviated as SUX, but I'll go over succinylcholine in just a little bit. And again, hypoxia can do this. Having that direct visualization during laryngoscopy can cause a vagaling down. So this is why we have atropine available to us in case the patient is likely to become bradycardic, which you can sometimes see in kids. And if the patient's already bradycardic to begin with, we can try this in order to prevent that from getting any worse, right? So those are the two main pre-treatment drugs. And so, for testing purposes, I might give you like a clinical vignette to say, okay, this is the situation the patient came in, they come in, this is their vital signs, which meds do you want to use for intubation, right? So you may need to make a decision on whether or not you want to give lidocaine or atropine in that situation, and then decide what are going to be appropriate induction agents and then paralytics based off of the case. So these are the kind of things I want you to kind of look at, are going to be like when to use these drugs, when not to use them, things like that are going to be sort of the questions I'm sort of trying to get you guys prepared for. In terms of induction agents, these are very similar to what we've looked at before when we were in the surgery section. Etomidate is a very popular one. I think the majority of the intubations I've ever been involved with used etomidate. And again, in my EMS buddies can probably speak to their experiences as well if they've used other things. I think Jackson was talking about using a lot of Versed. But here we can see etomidate is really nice because ideally we want to have medications have like a fast onset, so that way they go under very quickly in terms of consciousness, and then they can come back out of it really quickly. One of the things you got to be careful for is a lot of these drugs do have sedative properties. What if you need to do like a good neuro exam for your patient after being intubated? If you have someone who you suspect had a stroke or something, or might be having ongoing seizure activity, it's hard to tell if they're going to be so sedate from these drugs. And so that's why some people really like a short-acting med, because they can get a good neuro exam done after the patient has been successfully intubated. And so so your protocol is etomidate, Ativan, SUX, or Lido and atropine is needed. Yeah, there you go. So that's pretty consistent. Most of the protocols, or most of the experience I've run into, is usually etomidate. And then we didn't use a lot of benzos during the intubation itself, but certainly a lot of succinylcholine. And we'll talk about some of the other paralytic alternatives there. Because I saw etomidate and propofol a lot. A few docs started preferring ketamine when I left the ED. Definitely, we'll talk about all of those and when some might be better options than others there. So again, the nice thing too with etomidate is it has really, really minimal hemodynamic effects. So it really shouldn't affect the blood pressure, really shouldn't affect the heart rate at all when given. And this is as compared to some of the differences we'll see in some of the other ones like propofol and benzos and things like that. So this is why it gets preferred in a lot of cases. Fast offset, really minimal effects on the hemodynamic system. And again, it's working on those GABA neurons to try to increase the hyperpolarization and cause sedation to occur, just like we talked about before in the surgery section. Look at all these questions here. Let me, okay, so someone says a common to use pre-treatment drugs. Depends on the situation. Generally, no. But this is going to be on a very like ad hoc sort of basis. So if you know, so for instance, if you're working like in a trauma center, you're probably going to use a lot more lidocaine because you're going to see a lot more patients coming in with potential traumatic brain injuries, increases in ICP, things like that. So it might be more situational based on where you're working at. In peds, we maybe needed more atropine if we had like repeated doses of succinylcholine being given to a patient, because that's when kids tend to get a little bit more bradycardic. I'll talk about that later. But in general, if you had an otherwise healthy patient who, for whatever reason, needed to be intubated, generally, no, you don't have to use those pretreatment drugs. But that's why it's good to know when to use them. So someone says, sorry, but are you saying it causes them to vagal down? Yeah, so like if you have someone who is having, that laryngoscope blade being put in, and you are, moving the airway around and all of that. I'm motioning with my hand as a how you would do it. But basically that can cause the parasympathetic nervous system to sort of activate and cause the vagal nerve to be more active, release acetylcholine that's causing them the heart rate to drop. So that's kind of inappropriate, or not inappropriate, but sort of informal term is they vagal down. So it causes them to cause a heart rate to drop there. Someone says, does lidocaine have physiologic effects causing decreased ICP, or is it simply numbs the area that would otherwise cause increased ICP? So the goal is that it's trying to not necessarily numb it to where like if you're doing like a procedure like you were trying to suture someone up, it doesn't get like that degree of numbness, but it's trying to sort of blunt some of those nerves that would normally be activated during like the cough and gag reflex. So if you can kind of blunt some of that response, because again, if you imagine coughing or gagging, like you kind of bear down quite a bit, and that can cause increased pressure in the brain. Normally, that's not a problem because you don't have increased intracranial pressure, but for these patients who may have that can help to blunt some of that response there, and you won't get as big of a spike. You may still get some, but maybe not as much. That's the goal anyway. I don't know if we've really seen I don't know the data on it specifically, compared to placebo or something, but that's the idea. That's why we're doing it. Okay, back to the PowerPoint. So as I mentioned, it helps enhance GABA, our major inhibitory neurotransmitter there. And again, based off of how big of a dose you're giving, can go anywhere from light sleep to a deep coma. Typically, we're giving enough of a dose that way they are unconscious. Usually, a single dose is generally good for most patients to like knock them out. That way, when they get paralyzed, they have no sensation of anything going on. They should be completely out of it when they're getting this. And again, it can cause sort of similar EEG changes in terms of kind of slowing down the CNS, similar to things like barbiturates and benzos and things like that. So typically we'll use this either as like an induction agent. Like I said, in my experiences, I've used etomidate almost exclusively with intubations for RSI. Some people have seen it being used for things like procedural sedations, like in adults, for instance. If they didn't want to use propofol, they could use etomidate instead. But again, overall, it's very nice because it is so hemodynamically sort of neutral, which is not the case for all of these. And no big contraindications to speak of other than, if they have like a known hypersensitivity, which is exceedingly rare. Again, it's nice because it's a very rapid onset to loss of consciousness. Basically, the time it goes from the arm to the brain, going through the heart and the lungs and all of that, it kind of rapidly distributes to the CNS. But then, so it leads to fast onset, but then it also rapidly distributes out of the CNS as well, which is why you see it has a very short duration of action, which is generally what we're looking for in the case of intubations, right? Because we don't need them to be out for super long. Now, if you're moving up to the ICU and they're going to require ventilatory support for prolonged periods of time, then yeah, you're going to sedate them with other stuff as well. Versed and fentanyl are a popular combination there, propofol perhaps. But in the short term, right when you're intubating them, you still may need to do some assessments on the patient from like a neurologic standpoint. Having something with a good fast onset and fast offset is important, which is why etomidate is liked there. Again, don't worry about the dosing necessarily, but you can see here that, duration of action between 5 and 10 minutes or so. So again, the really peak effect you're going to see for that first few minutes. But you have to think about too is like, what if the intubation's not going as planned? It'd be nice if it was, kind of a one and done sort of thing there, but based on the anatomy of the patient, based on all sorts of issues that can happen there, you may need to consider things like redosing. So for instance, if we give our patient the medications and they're having several failed attempts and intubating, you start to see the patient kind of moving around some. It's like, hey, we need to redose here because, they're moving around, and that could mean that they're having some degree of consciousness, and that's not good at this moment here. And again, there's a wide variety of skills that people have in intubation. I can tell you that I'm actually really bad at it. They won't even let me try it at all. It was kind of a bum deal, but whatever. Just kidding. I tried on a mannequin. I was pretty good on that, but I don't think I'd be very good at people, as it turns out. But anyway, so this is where you're going to see, and typically, it's either respiratory therapists may be doing this, physicians, but certainly PAs, NPs, I've seen on many occasions that may need to do this if the need arises, right? But anyway, so short half-life, quick onset of action, quick onset, quick offset, very nice from that standpoint. Big things you're going to see here in terms of interactions is mainly that if it's going to have increased effect if you're combining with other sedatives, other hypnotic drugs like barbiturates, benzos, with opioids, certainly the patient's getting some like fentanyl or morphine, you're just going to see an enhanced effect. In this situation, probably not going to be a big deal because they're going to be getting intubated. So the worst thing that can happen is, they're going to be passed out and they may not be breathing as well for themselves, but now we've got them ventilated so we can breathe for them, and that's not really going to be a huge issue there. Someone said, would something with a fast offset be preferred in the geriatric population? So trying to think, if you still want that fast offset in the specific case of RSI because, if you want to switch them over to something else, for instance, if you're putting like Versed and fentanyl for continuous sedation for them while they're on the ventilator, you don't want to necessarily have that other drug sticking around for a while. But also, like I mentioned, if you need to do a neuro exam, which is the case that I've seen argued most from a physician's standpoint, they're like, well, I need, if I still need to do a neuro exam, if I have someone who thinks has a stroke, has to be intubated, in that case there, like I need to have them be somewhat conscious so I can do things like look at their eye movement and see if they can respond to commands and things like that. It may be a little uncomfortable for the patient since they have that tube down their throat, but again, that may be needed in some cases there. So still preferred in the geriatric population, and in general for like continuous sedation. You want short-acting meds anyway because those are going to be things you're going to be titrating to effect. So I don't want it to take a long time for that new steady state to be reached, which is why I use short-acting, benzos and opioids like fentanyl and Versed, because you can titrate those quite easily as compared to things that last forever. Like, you would never do a methadone drip because that would be really hard to titrate since the half-life of that stuff's like 50 hours. It would take you like a week just to get to a new steady state, which is not ideal. Okay. Some other things you can see with etomidate, some of the negatives here would be things like trismus, and you can get these myoclonic jerks that occur here. The trismus can be really not ideal from the intubation standpoint because if their jaw is starting to lock up, you may not be able to have enough mobility in order to get in there and get the endotracheal tube placed, because you do need to have some mobility there of the neck muscles in order to open up the pathway there. This is normally sort of ameliorated by the fact that you're giving a paralytic right afterwards. So if they do experience some trismus, generally it's going to be limited until they get the paralytic, and that generally will stop that. I've not seen it a whole lot, but certainly you can see some muscle twitching. Now, this is kind of tough too because we're going to talk about our neuromuscular blocking agents, our paralytics, and we're going to find some of those can actually cause fasciculations as well. So it's kind of tough to tell if they get etomidate and succinylcholine, which one's causing the twitching, but this can be seen occasionally. Let's see, someone said, why would you want something that has a fast offset if a patient's condition is severe enough to need intubation? Wouldn't you want them to continue to be sedated even after the procedure? Generally speaking, yes, but as I mentioned, in terms of being able to assess your patient, if they are completely sedate, you may not be able to do as good of an assessment for those patients, right? Now, typically what we'll see, if that's not going to be as much of a concern, is that you could have something with a fast offset, but then switch them over to something else that they may be on more on a semi-permanent basis. So what I would see a lot of times is that you would have a patient get intubated with the etomidate and the succinylcholine, and then you could then switch them over to like a fentanyl and Versed drip once the tube is placed. On the other hand, though, if you are having a lot of difficulty intubating that patient, you may not be able to do that. So you have kind of limited options at that point. So you can try to go back to more like an oral airway, in which case having a short onset or short offset drug is good because that patient can then still sort of breathe on their own to some degree. They won't have as much of a degree of respiratory depression. The other option is to do a cricothyrotomy, which is never going to be the preferred outcome. So having a short onset and offset drug can be sort of beneficial from that standpoint if intubation does not go well. Which, just depends on the case. Sometimes it's a one and done. You blink and you miss it sort of thing. Other times it can be quite challenging and can require many attempts. Sometimes you have to get the anesthesiology people to come down to do it. And it can be quite a disaster in some cases there. Jackson say, I never knew about the trismus, but experienced it several times, and our protocol for sucks was really strict. You mean in terms of like when you gave it, or how do you mean strict, I guess? I'm not sure. Or that you just always gave it, I wonder. The other thing too you're going to see with etomidate is this decreased plasma cortisol concentrations, and so this is, I mentioned this before. So luckily the succinylcholine choline should be able to deal with any of that, and I'll talk about sucks pretty extensively here in just a little bit, so don't get too worried about that. I want to kind of hit on the sedative meds first. But here with the plasma cortisol concentration drops that you can see there, that can be sort of problematic. So imagine you have someone who is septic coming in, they're already hypotensive due to this kind of body-wide inflammation due to infection, and now all of a sudden you're dropping their cortisol levels. Well, that makes it difficult to manage their blood pressure because that cortisol was important for keeping things like their blood volume up from the mineralocorticoid effects. And so you may need to do things like give supplemental hydrocortisone in order to kind of boost them back up until that sort of resolves. And so that's important to tell for, when you're doing sign out to wherever they're going, which presumably would be the ICU, say, hey, just FYI, they got, etomidate sucks for intubation. And that way the providers at least know they can kind of think about that sort of thing when they're dealing with the patient down the road there. Now, your benzos can be utilized here. I've had kind of variable effects with this. I find some providers, and again, a lot of like the drug decisions people make are either based off, like with EMS, it's usually based off of their protocol. So there's not like a lot of like independent decision making other than like, what does the protocol say to do? But a lot of like providers get very railroaded into like what they like to use, and they'll use that for like almost everybody, So a lot of this can be sort of just like inertia from what they've just used, and they know what they like, and they just stick with it. In a lot of cases there, usually your patient doesn't have a whole lot of decision making in this process since they're being intubated. But anyway, what you can see here is that the benzos are nice because they can do that sedation, amnesia, and then also if they're having seizures, it can provide some anticonvulsant properties as well. Just know there's no real analgesia here you're going to see. I've seen more Versed being used in the case of intubation specifically because it's more lipophilic, so it's a faster onset. Lorazepam is preferred in more situations like they're having seizures, mainly because of the fact it has a longer duration of action, can help to prevent some of those recurrent seizures there. Generally speaking, though, it may be a difference of a few minutes in terms of onset, so not a huge difference in the grand scheme of things. Here you can see sort of the normal dosing for Versed that we would do. And again, note here that the duration of action is going to be a lot longer than something like we saw with etomidate, which might be over, 5-10 minutes. This can be lasting maybe 15-20 minutes. So you have to kind of, assess like, okay, well, how long are these patients going to be under the effect of the medications? And we just know with something like Versed, it's going to be a lot longer than like etomidate. Someone said, etomidate causes muscle twitching as a side effect. How would you be able to tell if it's a side effect or the patient has to be redosed? So generally speaking, so I'll talk about the time frame of things, like when you're giving them. Typically, you're going to be giving the sedative drug maybe 2 to 3 minutes prior to giving the paralytic. And so you may see some of those fasciculations and things during that time frame. Once you get that paralytic, hopefully the patient's not going to be moving around very much at all. Once they start to, say it's been 5-10 minutes and you still haven't gotten the tube placed, and you start to see them sort of moving. At this point here, that's when you start to consider that, okay, well, the paralytic's wearing off. I can presume the sedative's wearing off as well. Now it should be time to redose. And, there's differences, and you'll see this between like myoclonic jerks and sort of like more purposeful movement of like someone waking up. So you can kind of, it may be difficult to tell the difference, but that's one thing you can kind of look for there. Hopefully this comports with what you're learning from Professor Q and all of that. I'm sure it's been pretty similar. or will be pretty similar depending on where you're at there. But with midazolam, you can see total duration usually about 1 to 4 hours, but in terms of like the actual like initial sedative effects there, it's that 15-20 minutes I mentioned there. In some cases where you may want to use lesser doses can be patients, geriatric patients, those with CHF, obesity. Some of that can kind of slow down the metabolism and excretion of the drug, so it'll have a little bit longer half-life. And so if you need sort of shorter effects, then this may be something to reduce the dose on. But again, if they're being intubated, chances are they're going to be sedated for at least a little while once things kind of get settled there, and so it may not be as big of an issue. Up next, again, one of my favorites, Special K, ketamine, derived from PCP. It's a dissociative anesthetic. It's blocking those NMDA receptors here. This is good because, again, it has a fast onset, duration of about 5 to 10 minutes or so. And this may actually be useful for patients who have either issues in terms of like low heart rate, low blood pressure, or if they're experiencing asthma, like we talked about before, which might have come up on a test question. This is nice because it releases catecholamines. So if I had someone who was coming in that was septic and was hypotensive, this might be actually a really good option for them. Either this or something like etomidate, which is neutral. This could actually raise that blood pressure up, and that may be beneficial. Also, bronchodilatory can be nice if you're intubating someone for status asthmaticus. The other nice thing too is that this actually helps to leave the respiratory drive intact, so people can still be spontaneously breathing, especially if the intubation is going to take a long time or if it's not going super well. Where I've run into this being used with some utility has been in cases of things like angioedema. I remember very distinctly a case where a gentleman was coming in and his lips were extremely enlarged. His tongue was sticking out of his mouth after angioedema experienced from, I believe it was lisinopril or one of the ACE inhibitors. And so this gentleman needed to be intubated because the worry is that continued swelling can eventually close off the airway. And so because we were worried about his respiratory drive being intact, we actually ended up using something like ketamine, and we were able to actually go and do a nasotracheal tube getting placed there. So we used the fiber optic camera to be able to place that, and then once we were down through the vocal cords, we could then kind of snake the tube right behind it, and so that way we were able to get the patient intubated there. So there could be some special uses for this, asthma being another case, or if they have like low blood pressure, this might be a good option for those patients there. Another question. So someone says for midazolam has a duration both 15 to 20 minutes and 1 to 4 hours with magic, obviously. No. I'm more talking about where you're seeing sort of like those peak sedative effects where they're going to be like out cold, so that way you can do the intubation, versus how long the residual effects on the drug are going to last. And so those residual effects, you may still have some effects of the drug for those several hours, but in order to actually intubate that patient, you have that 15 to 20 minute window. If you try to do that towards the end of the 4 hours, they're going to be way too awake in order for that to occur. So that's kind of what I'm getting at with that there. It seems a little duplicitous, but that's kind of the distinction there. I wish we had magic. I wonder how they intubate people in the wizarding world. What concoctions they use for that. Anyway, so some of the downsides for ketamine and why it's a little bit more kind of specialized and not used for everyone necessarily is, one thing, it can be a sialagogue, which is a fun way to say it increases saliva production. This is something that is questionable in terms of like clinical impact. If you imagine if you're trying to intubate someone, you're having a lot of secretions, they're sort of clouding your view a little bit, that can be tough. This can actually be blunted by atropine, because atropine is an anticholinergic, so it should dry everything out, so that can be sometimes useful, although not always necessary there. And then in this case here, it can cause a catecholamine release, which may actually increase intracranial pressure, although this is somewhat controversial. So if the case of, someone with like a traumatic brain injury, you're probably not going to use ketamine just because you'd rather not poke that bear, so to speak, and do anything that might increase their ICP. So we try to avoid that. Other things too, dysphoric reactions. This is less likely to be a problem here, mainly because you're going to be, again, putting the patient on continuous sedation generally after this. So, they're going to be sedate for that period, so they shouldn't really have any dysphoric reactions. That's more something you see when they're coming out of the drug, like once the drug starts to wear off. And then vomiting can be somewhat common with this as well. Again, not great if your patient vomits in the middle of you trying to intubate them. So in that case there, pre-treating with some Zofran or something may not be a bad idea in those cases. One thing, so you notice here, I put actually like administered over 2 to 4 minutes. This is because if you give most of these drugs you can give pretty rapid IV push. With ketamine, you want to do it a little bit slower because you can actually see some spikes up in things like blood pressure and heart rate due to that kind of that rapid administration. And I said we use this all the time for procedural sedations at Nemours. We had this one really cranky orthopedic surgeon, like I don't know who, he's probably operating on people back in the Flintstone days or something, but it's a real crotchety old guy, and he was just like, all right, speed up, let's get the ketamine. We're just like, well, we want to give it over a few minutes. He's like, just push it, and it was a nightmare. But sometimes you'll find the surgeons wanting to get things done real quick, especially when they're getting called in like Saturday night or something. Like it's just not fun. But anyway, let's see. Said, for ketamine, the catecholamine release more of a pro or a con? Both? Why not both, right? The taco commercial. In those cases there, pros being mainly that you can see if they have low blood pressure, that could be a good thing because it can bump up their pressure. If they have status asthmaticus, that's good because it can help to bronchodilate, right? If they have increased intracranial pressure, probably not a good thing because you can maybe see some spikes there. So again, a lot of these things kind of cut both ways, which is why you guys are going to be the clinicians that are so smart. You can make a decision saying, for this patient, it's a pro. For this other patient, it's a con. We're not going to do it, right? All right, so propofol next, milk of amnesia. Again, I know I showed you guys pictures before, but it's hard to tell in the white background. But again, that's a lipid emulsion that it's in that is, looks like milk basically. Push it real good. There you go. Exactly. Patient felt better afterwards, though, I can tell you that much, because they were not aware of the fact they had a displaced femur fracture, for sure. Anyway, so propofol we do like, again, because it has a very quick onset, short duration of action. This is another one you may see people want to do the intubation with the propofol, and then they'll just keep them on a propofol drip afterwards to maintain that sedation, because you could use this by itself. A lot of other people want to use fentanyl Versed. Usually that's going to be up to the ICU team that's going to be taking the patient, as opposed to you in the ER. Because again, we're kind of going from the ER perspective here. You may just decide what drug to use in the first place. And again, not to say that a lot of hospitals may not have protocols as well that sort of guide what people can use, but you as a provider get a little bit more sort of leeway in terms of what your decisions are going to be. But sometimes you may have kind of good practice standards to say, hey, this is what you should use 9 times out of 10. One thing you can see with propofol is it can actually cause hypotension. So this is something where if you had someone who had a coming in for sepsis or they were hypotensive, this might not be a great drug for them because it can actually end up dropping their pressure further. So if they're hypotensive to begin with, I don't really like propofol from that standpoint, since this is one is going to have kind of the most negative effects from that standpoint. Also, the lipid emulsion that it's in is based off of egg and soy protein, or has egg and soy proteins in there. And so if they have a history of an allergy to that, they should not get propofol, because it's not the allergy to the drug. It's just the egg and soy proteins that are in that emulsion to get it into solution, basically. So those are the main sort of sedative drugs that we're going to use to induce sedation for our patients. And I think most people, that kind of comports with what most people experiences there, what their experiences were. Now I want to talk about the paralytics, which are going to be kind of a new set of drugs here. So we're going to see how these actually work. Basically what we're going to find with our neuromuscular blockers, or NMBs, you may see them being referred to. Basically, this is going to block nerve transmission to skeletal muscle. So note that it's only going to be to skeletal muscle. So it doesn't do anything to the parasympathetic, the sympathetic nervous system. It doesn't do anything to your level of consciousness, your pain perception. It has no effect on seizure activity. Now, if someone's having tonic-clonic seizures and you give them a neuromuscular blocker, are they going to stop having tonic-clonic movements? For sure. Are they still seizing in their brain? Absolutely. So that's one of those things that can be a little bit misleading, is when you see the patient's like, okay, well, they're not having tonic-clonic seizures anymore. Everything's good. But then you get the bedside EEG and realize it's still going like crazy. So this is why you have to absolutely give sedatives beforehand in order to make sure the patient is not going to be conscious when they're getting the paralytic, because I imagine you would not want to be paralyzed without still being, aware and awake of what's going on around you, just because you're not going to be able to respond, right? So we're gonna have two main types of neuromuscular blockers here. We're gonna have our depolarizing neuromuscular blockers, which includes succinylcholine. It's the only drug in that category. And then we have our non-depolarizing neuromuscular blockers. That's going to include a few here, like pancuronium, rocuronium, vecuronium, and then we'll have a few others like cisatracurium we'll talk about briefly here. Some of these you're going to see used more so outside of the ED, like in the surgical setting, in the ICU setting. We'll still talk about them here because, you know, this is kind of the only time that we're going to have to talk about these drugs, or the only place it really fits in. So we're going to talk about the differences between these and sort of what you might expect to see when someone gets one of these, some of the downsides and upsides of one versus the other. So if you were looking at your motor neuron, again, like we've seen with our basically with our normal, you know, neuromuscular junctions, we're going to see the signal, the action potential is going to be traveling down these neurons here, and it will attach to the neuromuscular end plate, where it's going to release things like acetylcholine. Acetylcholine is going to be the major neurotransmitter we're focusing on here, and that's going to cause the skeletal muscle to depolarize to cause a contraction to occur, right? I don't have any pictures of that. Yeah, so you can see kind of what the neuromuscular junction looks like. So these nerves are going to be releasing acetylcholine onto the neuromuscular end plate, and that's going to lead to activation of the, you know, again, propagation of the action potential, leading to the actual muscle contracting there. So what we're going to find is that acetylcholine is really important for that to occur, right? So we know acetylcholine in its actions on the muscarinic receptors, we talked about that quite a bit throughout this past year or so, but we haven't really talked nearly as much about its activity on the skeletal muscle, on the nicotinic receptors, right? We have muscarinic and nicotinic receptors. The nicotinic ones are the ones we're going to be focusing on here. And so normally what happens is you would release acetylcholine, then you have the enzyme acetylcholine. Okay, looks like it's back. Great. Sorry if I'm freezing for you guys, but anyway, so the acetylcholine is going to be broken down by acetylcholine esterase, and then that will end the contraction basically there. That choline can then be kind of reuptaken and be reutilized to make new acetylcholine at that point there. So again, they're still having some recycling going on at that point. So first off, I want to talk about succinylcholine, or Nactine's brand name you may see for it. This is the only depolarizing paralytic that we use clinically, and so the reason why some people will like it is it causes rapid onset and it has a short duration, very similar to what we saw with stuff like etomidate, right? So what is acetylcholine going to be doing for us, and what makes it a depolarizing neuromuscular blocker? Well, if you actually look at the structure of succinylcholine, it's basically two acetylcholine molecules put together. And so what you're going to see is that it's going to be able to bind to those nicotinic receptors. It's going to cause them to activate, which initially does cause contractions of the muscles, which is why you can see fasciculations happening. It's going to depolarize the muscles, but then it's going to stay stuck to those receptors and basically tire them out. It's going to desensitize them and make them less able to fire off and have new action potentials. So what you'll find is that they'll initially have fasciculations, they'll have contractions of the muscle that then tire out, and then they will become flaccid. They'll become paralyzed, basically. Now, succinylcholine is also, because it's two acetylcholine molecules put together, it's also metabolized through plasma esterases. You'll have some people who have good plasma esterases, some people have slower plasma esterases, which may affect how long the drug actually works. But again, generally speaking, 5-10 minutes is the main duration of action you're going to see for these paralytics here. So, as I mentioned, it's going to be sitting there and it's going to cause prolonged stimulation of the acetylcholine receptor. So you get sort of a disorganized muscle contractions, right? Those fasciculations there as they initially get stimulated, but as they stick on there, you're going to find there's going to be a lot of potassium leaving the cell, sodium coming into the cell, and it's basically going to lead to it becoming very tired out and staying in the refractory period, right? We always talk about how with action potentials, you have a point where you have a refractory period, and some of those channels will start to close down, and you can have the ATP, sodium potassium ATPase pump kind of getting things back to resting memory potential. That process is being inhibited, so it can't really kind of get out of the refractory period, so it stays in a flaccid sort of state there, which is what we're shooting for. Not only that, but the acetylcholine receptors themselves, they get so desensitized that they then won't allow natural acetylcholine to come in and actually cause the action potential, okay? So that's the main way we're going to be seeing the paralysis actually occurring here. You're keeping the cell in the refractory period, and you're desensitizing the acetylcholine receptors, so that way acetylcholine, even if it did come along, could not activate those nicotinic receptors there. Okay. Once the succinylcholine is going to be metabolized and removed, then eventually those receptors can sort of get back to their baseline. The cell can get out of the refractory period, and then you can have natural, normal movements again of the muscle itself. So a little bit more of a complicated method there, but again, people like it because it does have that rapid onset. You'll see those fasciculations, and then you'll see no movement whatsoever. The patient will be nice and loose, and then you'll have a very short duration of action. Within 5-10 minutes or so, it should start to wear off, and the patient can start to move again, basically. So again, basically, you can kind of sum up the actions like I was talking about before. If you wanted to get it down to the more kind of brass tacks here, it's binding to nicotinic receptors. It's going to cause initial depolarization, then hyperpolarization of the neurons, and then block further binding because it desensitizes all those receptors there. Someone said, sorry, I'm a little behind. No problem. Can you explain why stimulating the gag reflex during laryngoscopy increases ICP? So if you imagine coughing or gagging, like you kind of have a lot of bearing down that you do when that occurs. I'm sure you probably experienced that. That can lead to increased pressure up on the CNS, and so that can lead to increased pressure on the brain. So if you have natural, normal ICP levels, that's usually not going to be a problem because your brain has a tolerance it works within. But if you have already high ICP, and then you're going to exacerbate that by causing the gag or the cough reflex to be activated, that can cause further spikes. And that's what we're worried about is, things like herniation happening during those spikes there. So that's why you would see that. Hopefully that answers your question. Just imagine coughing, like how much you bear down, or if like you sneeze or vomit or something, how much you bear down when that happens, and imagine that pressure kind of building up on your brain. And that's how I kind of think about it there. So there's contraindications. There's going to be some cases here where you definitely do not want to use succinylcholine, and this is why a lot of people do not like to use it. And I'll tell you kind of my experiences. A lot of the older school physicians that I've worked with, they've always used succinylcholine, and that's what they're going to continue to always use because that's just what works for them. I have a lot of newer providers coming out, either PAs, NPs, physicians who come out, and they some of the physicians are coming fresh out of residency or fellowship, and they're like, I've never used succinylcholine once in my life, right? Because you're going to see that a lot of these contraindications make it more difficult to use, or you have to think more about how you're going to use this drug to make sure you're not going to give it to the wrong type of patient. There are more wrong types of patients to receive succinylcholine than you'll see for a lot of the other non-depolarizing neuromuscular blockers. Okay, so let me go over the list here. Basically, the problem with these cases here is that a lot of these can cause upregulation of these potassium channels that happen, that can occur, right? So things like severe burns, crush injuries, spinal cord injuries, over time you can find they have kind of this increased number of potassium transporters that are open or that are available. When you have succinylcholine depolarizing all of these nerves, you're going to see a lot of that potassium is going to flood out because you have more transporters. You're going to get much more potassium coming out, and it can lead to hyperkalemia. We always expect that the potassium can rise transiently with succinylcholine, but for someone who already has a sensitivity to this effect, or if they already have pre-existing hyperkalemia, this can be a problem, can lead to arrhythmias. So this is why you got to be careful there, right? So for things like severe burns, notice the time frame. It takes time for the body to start to upregulate those potassium channels. So within 2 to 3 days or so. So they've had a severe burn, crush injuries, spinal cord injuries. It takes 2 to 3 days or so before this is really going to be an issue. So if I'm working in the trauma center and someone comes in, I remember one really bad case where a patient was a long-term COPD patient. They were on oxygen. They were still smoking. They were over a gas stove. And guess what happens when you have concentrated oxygen, gas, and a spark? Hoo boy, it blew up. And this patient came in. It looked like he'd just been coming off of a charcoal grill or something. In that case there, it's still okay to use succinylcholine. It's only if it was 2 or 3 days later would that be the problem. Okay, it takes time for this to sort of re-equilibrate. You can't see with succinylcholine, all those fasciculations can potentially increase intraocular pressure. So if they have narrow angle glaucoma, this would be another contraindication. In addition to your inhaled anesthetics like sevoflurane, isoflurane, things like that, this drug in particular can also cause malignant hyperthermia. Like I said, the two places you're always going to find a malignant hyperthermia cart are going to be in the OR, where you're going to use all your general anesthetics, and in the ER, where you're going to use succinylcholine. And remember, what's in that cart? Cool IV fluids, bicarb, and dantrolene. Dantrolene is the treatment of choice for malignant hyperthermia. So if you have a chance to ask the patient or the family, hey, do you have any previous history, any family history of bad reactions to anesthesia? Even if they don't know specifically it was malignant hyperthermia, you can kind of get it based off of context clues and say, okay, this might not be a good drug for this particular patient here. Other things like neuromuscular disease, like trying to think, like Duchenne's muscular dystrophy is a good example, at least for like children. If they have this also leads to the similar actions here with the increase in potassium channels. So that would be another case where you don't want to use that. And then if they have a pseudocholinesterase deficiency, this means they can't metabolize it as well. It just means the drug's going to last for longer. So that's going to be more of a relative contraindication. You're not going to know for a lot of patients that they have this unless they've specifically been tested for it. And then I mentioned hyperkalemia. So the potassium's already elevated. You don't want to give any more succinylcholine because that's just going to push it up even further. Okay. So as I mentioned with the adverse effects, you're going to see the fasciculations. You're going to see hyperkalemia. Usually it's pretty transient. I think you usually get between a 0.5 to 1 milliequivalent per liter bump in your potassium, which most patients can usually tolerate. If you normally sit at a level of 4 and it went up to 5 briefly, that's still normal. That's fine. If you're already at a 6 and it bumps up to 7, that's not great. Right. Other things we can see is that because we do have something activating these nicotinic receptors, remember in the parasympathetic nervous system, you do have some presynaptic nicotinic receptors that can be activated. So this can cause bradycardia, especially if you need multiple doses. You're more likely to see that bradycardia. And again, the treatment for that is just to give atropine, just like we saw before for the pretreatment there. The prolonged neuromuscular blockades, more so if they have that pseudocholinesterase deficiency, but this is pretty rare. And then that malignant hyperthermia, if they have that family history, that should be a big clue as to not administer this. Someone said, just to clarify, all those conditions would cause hyperkalemia. We wouldn't want to give sucks because of that. Why? So as I mentioned, so specifically the burn injuries, crush injuries, spinal cord injuries, the neuromuscular disease, all of those are going to lead to the muscles having an upregulation of these potassium transporters. When you activate those muscles with the succinylcholine, because you get the initial activation, that's going to cause a whole lot of potassium to flood out of that cell. And because you have more transporters, even more of it's going to flood out than normal. So whereas with a typical patient, you may get like a 0.5 to 1 milliequivalent per liter bump of their potassium, it could be above 1. It could be more than that. And again, not going to be good, especially if they have hyperkalemia to begin with. So that's why we kind of avoid it for those patients there. And again, remember the time frame for some of those. Burns, crush injury, spinal cord injury, it takes 2 or 3 days for that to really start to be a problem there. Okay, so that is why. Can you please explain the mechanism for the increase in potassium with succinylcholine? Again, thank you. Yes, absolutely. So if you recall, let's see, I wonder if I can find skeletal muscle action potential. Trying to find a good example here. It's not the best thing here, but so if you're looking at this picture here, imagine you have this depolarization. Remember what causes the initial depolarization? Well, it's the opening of sodium channels coming in that causes this to rise rapidly. Well, what causes the repolarization? Well, it's your potassium efflux, right? There's a potassium channels opening up, causing the repolarization of the cell, and then eventually those will close, and then you have the sodium potassium pump that's going to be bringing potassium into the cell, pushing sodium out of the cell to get you back to your resting membrane potential. So if I'm in a case where I have a whole lot more of these potassium channels than normal, I'm going to get all of these flooding open once that succinylcholine initially activates it, causing the depolarization. All this is going to flood out, causing that hyperkalemia to occur there. So hopefully that makes a sense. I think this picture is probably a little bit better here. So notice here during that repolarization, K out, although that's calcium in, so that's more so probably like a myocardial cell. But anyway, so hopefully that makes a sense there. So it's potassium efflux during that repolarization is what's causing the problem of the hyperkalemia, if that makes a sense. Okay. Someone's trying to hide one out of here. Don't be hiding your sticky notes. Let them shine, people. Let them shine. Can you explain why sucks is contraindicated only in burns that occurred more than 48 hours ago? So someone came with severe burn that happened an hour ago, you can use it? Yeah, so just like I mentioned with that person who kind of blew themselves up, that's totally fine. You can use it. It takes the muscle time for it to upregulate those potassium channels, usually 2 to 3 days. So that's why you end up having to see that. So I could put on a test question. I could say a patient had a history of burn injury 3 hours ago covering, 50% body surface area. They need to be intubated because maybe they're getting, sick or septic or something and they need to be intubated. That would be a contraindication. You would not want to use it in those cases there. Succinylcholine. If it was something that happened 15, 20 minutes ago, you're totally good to go. No problem there. Say someone said so it would take at least 48 hours if a patient had a crush injury or burn in order to see the hyperkalemic response. Yes, because again, that after that time frame, the 48 to 72 hours is when you're seeing that upregulation of those potassium channels, when you're going to see that exaggerated response, right? Everyone's going to have a little bit of hyperkalemia, or at least a bump in their potassium when receiving succinylcholine. It's just going to be much more pronounced and exaggerated for these particular patients after that time frame. That makes sense. And this is like it's kind of a weird sort of abstract sort of concept, which is why I get questions like this all the time when teaching this. So don't worry about if you feel like you're not quite getting it. Even after this lecture, if you just want me to go through it again, totally fine. I don't mind doing that for you guys. So again, with the fasciculation, sometimes it's thought to have cause an increase in ICP and the intraocular pressure, which is why I mentioned that glaucoma being a relative contraindication there. Sorry, I forgot to go back to my slides. Don't yell at me, please. I'm sorry. So in terms of like the really clinically important ones, obviously if they have an increased ICP, this is going to be much more deleterious to the patient if they do not, if they had that big spike there. Yeah, Kelly, you're absolutely right. So less than 48 hours, you're fine. More than 48 hours, no go, basically. Again, some of this is maybe related to the muscles sort of contracting, causing, random spikes in the ICP. But again, sometimes what they can do is called a defasciculating dose of a non-depolarizing neuromuscular blocker. So sometimes they use the drug rocuronium, which I'll talk about in just a moment. But honestly, if you're at a point where you're trying to keep the patient from fasciculating because you're worried about stuff like ICP, so you're going to give a different paralytic, just use that other paralytic. And so I'm going to tell you that a lot of old school providers, they love succinylcholine. That's just what they've used. They're used to it. Because of all those contraindications, because it gets complicated like that, a lot of people are just like, well, I don't even have to think about with these other ones. I'm just going to go with those. And so that's what I'm going to talk about next when we get into the depolarizing ones, once we get into that point there. So as I mentioned, the hyperkalemia, normal rise in serum potassium 0.5 to 1. Perfectly acceptable for most individuals, not going to be a problem there. But as I mentioned, sometimes you may see even, further rise. Like I mentioned, that receptor upregulation in the case like we're talking about with crush and burn injuries. Or what if they already had something where they're having a lot of muscle breakdown, releasing a lot of potassium in the first place? So rhabdomyolysis could be a case like that, where you could see an even more exaggerated response. And this can be life-threatening. And as I mentioned, 4 to 5 days post, those like spinal cord injuries and things like that tend to be sort of the most critical. If they have any kind of ongoing neuromuscular condition like muscular dystrophy, then they're always going to be at risk for that. That's never going to go away. So that's why we end up seeing that there. So, as I mentioned, so we get some, and again, it's not just potassium channels are kind of overactive. Here we're also seeing an upregulation in the number of nicotinic acetylcholine receptors for these patients as well. So like I mentioned, denervation, neuromuscular disorders, crush injuries, other cases where we may run into this, which is less common, would be things like intra-abdominal infections, myopathies, but really those other ones I listed on that slide of contraindications, those are the big ones I want you to know from that standpoint there. Okay. So as I mentioned, the malignant hyperthermia is a risk for those inhaled anesthetics, the general anesthetics we talked about, and then also for succinylcholine. Oh, my straw's stuck in the ice. So if a patient had a family history of this, or if you start to notice after they got the succinylcholine, they have this big spike in temperature, you're starting to see their pH is maybe dipping down, or maybe start to see their PCO2 start to spike up all of a sudden, rhabdo, DIC can happen as a result of this. So these are the things we'd be looking for, and you need really prompt treatment in order to prevent things from going haywire and leading to rhabdo and disseminated intravascular coagulation and things like that. Just remember, cool the patient down, correct the acidosis, and give them dantrolene. Those are the big things we're going to do for those patients with MH there. Okay. Let's see. Yeah, we kind of talked about this before as well. So you can see a lot of this is due to that altered ryanodine receptor causing too much calcium to be released from the sarcoplasmic reticulum. Again, all kinds of problems here in terms of things like muscular rigidity, right? You can see autonomic instability, myoglobinemia, which can cause the kidneys to clog up. Not great. So if you can avoid this or treat it really early before a lot of this kind of damage has been done, you're going to be much better off than if you kind of wait to see it, which is why there's a lot of education that goes into being able to recognize malignant hyperthermia, especially if you're going to be using the drugs that are more likely to cause it. So basically the ones we've covered: general anesthetics, inhaled anesthetics, and then the succinylcholine here. There's no specific reversal agent here, but some thought that we can give the atropine. This can actually help to reverse some of the bradycardia. So that's one thing you may see being used occasionally there, especially if the patient's getting repeated doses. Bradycardia is more likely, especially in kids. So that's why we use atropine from that standpoint. So as I mentioned, if you're going to be giving succinylcholine, the patient's already bradycardic, you can go and pre-treat with atropine if you want. If you're worried about increased ICP, give the lidocaine beforehand, right? But just be careful, because if you're using succinylcholine and not being really cognizant of the patient that you're using it on, can be lethal, right? So just be really cautious from that standpoint. And remember, the paralytics have no effect on consciousness, so you have to give the sedative beforehand, usually 2 to 3 minutes beforehand, so it has a chance to kick in. So let's talk about the non-depolarizing neuromuscular blockers. You're going to see these are so much easier, right? So you're going to say, well, why would anyone use sucks? Everyone says sucks, and rocuronium rocks. So just go with that. You know, I think succinylcholine still has some place. I think it still can be a really good drug. Most of the time, it's going to be fine. It's just you have to be really cognizant of what type of patient you're dealing with. But for vecuronium and rocuronium, their big difference here is that instead of activating and then desensitizing the acetylcholine receptor, instead what they're going to do is to just sit on that nicotinic receptor and prevent acetylcholine from interacting with it. So a much more simple mechanism is just directly antagonizing it, as opposed to activating it and then desensitizing it. Remember, similar to succinylcholine, no effect on sedation, amnesia, analgesic properties. They just are not going to be able to move any skeletal muscle, depending on how much they're giving there. Vecuronium is one of the common ones you're going to see. I see this used more so in the ICU type of setting here. It actually comes as a freeze-dried powder and has to be reconstituted, so that takes like an extra step, which is why a lot of people in ER don't like to use it necessarily there. But you'll find it used in all kinds, like in cardiovascular, pulmonary emergencies, especially if patients are on the ventilator long term and they need to be more compliant with it. Sometimes paralytic drips will be used in order to try to keep the patients down. I'll talk more about degrees of paralysis here in just a little bit. But again, pretty fast onset, duration of action about 20 to 30 minutes or so, which is generally preferred. Sucks is going to be a little bit shorter than that, which is why a lot of people like it from that standpoint. So I know when we were opening up Nemours, it was pretty contentious in the ER, because our chief of the ER, he was more of an old school provider. He wanted to make sure that everyone's doing the same thing that he did, so that way it's always consistent care, and said, okay, everyone's going to use etomidate and succinylcholine. And a lot of our newer providers, younger providers, were like, well, I don't want to use succinylcholine. They're using it a day in my life. But a lot of it had to do with him really wanting to use it from the fact that it had a shorter duration of action. So if you need to do a good neuro exam, that's much easier than if you have something that's lasting 20, 30 minutes, right? Because again, that time may be really critical depending on the situation there. So patients with liver failure want to be really careful with VEC, because it can take twice as long in terms of recovery time. And again, the least amount of time patients can be paralyzed is generally a good thing. We're going to find there's some complications with sort of chronic paralyzation for these patients here. Other benefits: no real effect on heart rate, no effect on blood pressure, very neutral from that standpoint. So you don't really get that kind of variability like you might see with something like succinylcholine causing bradycardia, for instance. Rocuronium is something I use much more commonly in the ER setting. So like I said, I see a lot of VEC in the ICUs. I see a lot of rock in the ER. Again, that's sort of our slang terms we use for that. So if that doesn't make sense, let me know. Otherwise, we like it because it's just kind of ready to go in the vial. You can give it right away. Also, you're going to find that some older paralytics has kind of some vagolytic properties, meaning it kind of decreases the parasympathetic nervous system activity, which could lead to things like tachycardia. VEC and rocuronium really don't have any of that, so it's not really going to be a big concern that we're going to be running into here for the most part. Again, they're working by that competitive blockade of acetylcholine on those nicotinic receptors, so you don't get any fasciculations. You just get a smooth, flaccid paralysis that happens at that point there, as soon as it's being given. can be reversed, though, by increasing the concentration of acetylcholine, though. So this is kind of interesting how we can use drugs that block acetylcholinesterase to increase the amount of acetylcholine that we have available that will basically kick the neuromuscular blockers off of the receptor. So here's an example here of a drug called neostigmine, where it basically works to block that acetylcholinesterase and will provide more acetylcholine to remove the neuromuscular blocker off the receptor, and then you get normal neuromuscular transmission again. Note that this would not work for succinylcholine, because if you tried to do that for succinylcholine, you'd worsen the desensitization on those receptors because they're just being more activated at that point, right? Someone said, so if you wanted to do a neuro exam, would you want to use succinylcholine over VEC? That is the thought process for some providers. That's why I said they would like to use succinylcholine over vecuronium. Now, am I going to give you a test question where I'm saying you have this type of patient come in, you make the decision between succinylcholine and like rocuronium? Not based off of something like if you wanted to do a neuro exam afterwards. I think that's going to be much more of sort of a gray sort of matter there. However, I might ask you, okay, what's the paralytic of choice for this patient who has a history of they had Duchenne's muscular dystrophy? Well, in that case, succinylcholine is going to be contraindicated, so you wouldn't want to use it for those type of patients, right? So VEC might be a better option there. Someone said, why would you reverse rocuronium versus just letting it wear off on its own? Well, think about if you needed the patient to recover quickly, right? So if I had a patient who is in the OR who's receiving a paralytic to allow for flaccid paralysis in order for the surgeon to go in, cut into the belly or something to do what they need to do, and then you wanted the patient to sort of recover much more quickly, that's where you can use a neostigmine. And so 9 times out of 10, that's where we're going to be using it, is in the OR setting. A lot of times in the ICU, in the ER setting, you just let it wear off on its own. Okay, so that's kind of the big difference you'd see between the two there. Someone said, if you accidentally give someone who is conscious rocuronium, can that kill them because their muscles are paralyzed and they won't be able to breathe on their own? Is this for personal or intellectual curiosity, I wonder? I would say from an intellectual curiosity standpoint, that yes, if you gave someone a conscious person or an unconscious person from that standpoint, if you gave them rocuronium, what you would find is that they would have certainly skeletal muscle paralysis. The thing that's going to kill them, though, is that they're going to have paralysis of the diaphragm and the intercostal muscles. They will not be able to ventilate anymore, and that's what kills the patient. Okay. I was about to say, and again, you can pick up a lot of these drugs on the forensic screen, so I would not recommend this. As a guy who knows a lot about toxicology, I can definitely say what will show up and what won't, and so this might not be the best option for you. So thank you for not signing your initials at the end of that. It could be incriminating potentially. In the example you gave for succinylcholine, did I mishear how long ago the burn was? Did you say 3 hours post burn? Succinylcholine is contraindicated. If I said hours, I meant days. So I probably misspoke there. If I did, but you can go back and check the tape and tell me, was I wrong or not? But correct, 3 days. If I said 3 hours on the test, then succinylcholine could still be good to go, right? Or if I told you their potassium was like 7, which drug do you want to use? Then, succinylcholine would not be a good option there. So, all right. Again, this is another good one, fast onset. Kind of variable duration of action here, a little bit longer, it looks like, than VEC, but we still like it in the ER, so usually 20-30 minutes is usually the longest I'll see it end up working there. And then if you need repeated doses, you kind of just give the same dose again, and then you should have similar degree of paralyzation there. So, as I mentioned, any of these paralytics do not stop seizure activity. It just stops the neuromuscular effects of that seizure there. So if you're going to be giving anyone with a seizure paralytic, you want to consider having something like a bedside EEG being done to make sure that they're not in a now non-convulsive status epilepticus or something like that. Or if you're going to give an anticonvulsant, doing it beforehand, just to make sure that they, see if that treats the seizure before they get the paralytic. But honestly, the bedside EEG is generally the best thing in those situations there. They're probably going to need it anyway. If they're seizing so bad they need to be intubated, you're probably going to have that EEG regardless. So a couple other ones you might run into more so in the ICU sort of setting. Here we have pancuronium, which is a non-depolarizing neuromuscular blocker. Same mechanism as ROC and vecuronium. Brian saying, I think there was a case a few years ago where a nurse mixed up the meds and gave a patient VEC instead of Versed. That would be pretty bad, I imagine. Now, again, if you're in a hospital setting, if you could recognize it quickly enough, you can certainly get in there and intubate the patient or breathe for them, whatever you need to do. You could even probably do bag valve mask until the drug wears off, if you needed to. However, and it's funny because you think about stuff like, man, how do people make these mistakes? It's vecuronium versus Versed. They both start with a V, but how similar are they? I will tell you, sometimes people go out of their way to cause medical errors. Okay, let me give you an example. This is one my wife actually caught, where the patient was ordered oral lorazepam. Okay, came in a little oral syringe. It was a liquid because the patient couldn't take tablets. Okay, the nurse that got that drug, and again, this is not a slight on nurses because again, I see medical errors happen at every level of the medical chain there, but this happened to be a nurse, and the nurse was not familiar with oral liquid lorazepam. She'd only ever seen it given IV, and she's like, "Why is it in this funny syringe? I can't even hook it up to my IV site because it didn't." The normal locks you see on IVs are called Luer locks, LUER locks. And the oral syringes are designed by nature, or by design, to not hook up to those because you don't want to give oral meds IV. So you think that at that point, when the things didn't connect together, she would be like, wow, something's weird here. Perhaps I should ask somebody a question. She did not. She took that oral medication out of the oral syringe, put it into an IV syringe, and then administered it that way. So again, sometimes people go out of their way to do things incorrectly without stopping to ask questions, and that can happen to any of us. So you can be very careful here. Stuff like that, while it may seem pretty obvious, may not be in the moment. So just something to think about. Anyway, so pancuronium, cisatracurium drugs you're going to see more so in the ICU sort of setting. They're usually for more kind of like prolonged sort of paralysis, usually to keep people either from moving, which may affect things like intracranial pressure, or if you need them to be really synchronous with the vent and maybe they're kind of fighting you, or they have some sort of decreased ability to be synchronous with the vent. These can be used in those sort of cases there. I see a lot of Nimbex drips being used in the ICU. With pancuronium, this one is kind of an older school drug. I don't see it used a whole lot, at least in pediatrics. Have some little experience with this in adults, but it can cause a vagolytic effect. So as I mentioned before, that's where you're kind of decreasing activity of the parasympathetic nervous system. And that decrease of acetylcholine on those muscarinic receptors of the heart can actually cause a tachycardia. It may not be great for patients who have cardiovascular concerns, right? Previous MI and things like that. It's going to increase O2 demand on the heart there. On the other hand, Nimbex does not have any issues in terms of like renal hepatic metabolism, does not have any vagolytic effects, which is why I see it's kind of more popular nowadays. I think for a long time, pancuronium was cheap and cisatracurium was brand new, and it was, just kind of preferred because it was cheaper. Nowadays, I see a lot more Nimbex being used. So, I think overall the safety profile is a little bit better for that one. A little more intermediate acting, so you wouldn't use it for intubation necessarily when you want something more short. So specifically for intubations, most are going to see VEC or rocuronium or succinylcholine. These ones are going to be more so for patients who are intubated that need to be kept still for longer periods of time, maybe days, maybe weeks, who knows. So, someone a question. Someone said, are both vecuronium and rocuronium reversed by acetylcholinesterase inhibitors? That is correct, right? Again, all the non-depolarizing neuromuscular blockers are just sitting on that acetylcholine receptor on the nicotinic receptor to prevent acetylcholine from activating it. So any of them could be reversed by an acetylcholinesterase inhibitor. Okay. The only thing that would not be helped by that would be succinylcholine because its mechanism is just different, right? All right. Again, I love the questions. Thank you for being engaged and interactive. I appreciate that. So what are some reasons why we might use neuromuscular blockers for long-term paralysis? Because it seems like kind of like a barbaric kind of thing to do. It's like you don't like to put physical restraints on a patient if you don't have to. Why would you want to paralyze them? Well, there are medically necessary reasons to do so. So for instance, anytime a patient might be moving around, that can have a potential to increase intracranial pressure. So if someone who already has a high level, that could be bad. I've had cases where patients who, for instance, had like a craniotomy done, so had a kind of partial bit of their bone removed there in order to allow for that pressure to relax, and we had to keep the patient dead still because really any movement they had would cause them to bump their ICP, so we end up having to use long-term paralysis for that. Sometimes we'll do this if we have patients who are undergoing therapeutic hypothermia, so we're cooling the patient down to hopefully preserve brain function or heart function. Your body resists hypothermia by trying to shiver, right? Because it wants to shiver to generate heat. to get back to its normal homeostatic temperature, 98.6 or whatever happens to be, 36 degrees centigrade, if you will. So from that standpoint there, by paralyzing the patient prevents them from shivering, and that can be useful there. We actually will sometimes use meperidine. If you remember, we talked about that being used for Rigers in the OR setting. Sometimes we'll use that as well. It's an opioid we'll use sometimes for shivering. And then for facilitating like diagnostic or therapeutic procedures. So if you had someone who you needed to keep deadly still for something like an MRI and they already happen to be intubated, you could do that. If they needed to do something like bronchoalveolar lavage, sometimes you may get a dose of paralytic to help them kind of keep them still for that. Lots of things. But the problem is that the more that they are sitting there on that bed, not moving around whatsoever, their risks do increase for a various number of conditions. So things like VTE. So if they're going to be paralyzed, all that venous blood just sitting there in their legs is going to sit there and start to clot off. So what do we do to prevent that? Well, you can use things like Lovenox and other anticoagulant drugs like that. You can put them in sequential compression devices. Those all can be useful and are going to be part of that sort of that ventilator sort of checklist of things you want to make sure these patients are on when they're going to be vented for a long period of time, even more so when they're going to be paralyzed, because they are really not able to protect their airway whatsoever. Ventilator-associated pneumonias are more common here. See things like corneal abrasions because they can't blink anymore. So you need to make sure they have stuff like liquid tears or some kind of even some of the sticks around a little bit longer, some kind of lipophilic compound you can place in the eyes to make sure that they are not going to get corneal abrasions. And even like really long term, you can see these ICU neuropathies where if they're on it for a while, even if you were to take them off the paralytic and the drug is gone, they may have a hard time getting normal neuromuscular function back. And these are for patients that are paralyzed for like weeks or months potentially. Hopefully not for months, but. So this is a really cool thing that we can use to determine the degree of paralysis that the patient has. And so this is called a train of 4 monitor. And I thought this was super cool because I got to play with one of these when I was rotating in the ICU back as a student. And basically you can use the ulnar nerve, it's probably most common, and you can place this little device, has these little electrodes on it. And basically what they're going to do is it'll send 4 signals. And so again, when you're looking at the degree of paralysis that you need, you may not need full and complete and total paralysis of every skeletal muscle. You just need a little bit of help, maybe, just a moderate degree of paralysis. And so if you were to put this on me or you, they don't have any paralyzing agents on board, we would likely have 4 twitches. You get every single one of those, so you basically see the thumb kind of twitch like that. That would be someone who has 0 to 75% of those receptors blocked, basically, right? Even if you have 75% of them blocked, they can still have decent neuromuscular function there. If they have 3 twitches and you have about 75% blocked, if you have 2 twitches, 80%, and then 1 to 0 is between 90 and 100%. So 0 twitches getting through would mean they are completely and totally paralyzed. Not usually ideal. So if we get them to around 1 to 2 twitches, that is generally good for our purposes for things like, synchrony with event and things like that. So that's kind of the goal with that. So you'll see that being used, and it'll be like on the nurse's flow charts and stuff, talking about how many twitches they had on the train of 4. Someone said, can you give patients neuromuscular blockers and not give them anesthetics so they're paralyzed but conscious, like you were saying during the MRI? You would never, ever, ever want to do that unless you really disliked having like your job or a license or something. I'm not sure if you could lose your license necessarily, but that would not be great because, again, the patient's going to be conscious of everything. So you absolutely have to have some sort of sedative on board. And again, generally speaking, imagine if you're going for an MRI, you get patients who are, say they're on the ventilator, they're up in the ICU, they need the MRI done. They may be on a drip of Versed and fentanyl, and that's enough to keep them still enough that where it's not going to be a problem. You could then add on a paralytic if you need to, but you would never do the opposite. You would never give them a paralytic with no form of sedation on board. Okay. Shelby's saying, when you say synchrony with the vent, is that trying to keep them from breathing over the vent? Yes. So in some cases they may be trying to breathe on their own, or there's some kind of dysynchrony happening between the ventilator settings and what they're trying to do. So by trying to paralyze it somewhat, it allows the vent to kind of do all the work for them in some cases. Specific indications when that's going to be more important than others, I don't really know. It's not really my wheelhouse. I'm sure someone working like respiratory therapy or a pulmonologist or ICU doc or someone can give you more info on that for sure. Some say if you give a patient a neuromuscular blocker, they have to be mechanically ventilated somehow. Correct. Generally speaking, yes. So they will not be able to breathe on their own if they're going to be paralyzed because basically the diaphragm, the intercostal muscles are going to be not functional. So this is why you'll normally see this like in the surgical setting where they're going to be getting intubated by anesthesiology anyway, ICU setting, ER setting, but not really anywhere else outside of that. Those are the three main places you're going to find paralytics being used. And again, these are treated with like they're a loaded gun basically, because if you accidentally give this to someone and you don't have any respiratory support around, it's pretty easy to kill somebody or cause some major harm to them. And so usually there's like big stickers all over the spots in the hospital where the paralytics are, big warning labels saying, hey, this is a paralytic, be really careful before you give this, because of errors like giving vecuronium instead of Versed. That could be absolutely fatal, right? So that's why we're breathing for them. Usually with invasive, ventilation, like a ventilator, I should say. So anyway, so going back to intubation specifically, like what do we do if things don't go as planned? Keep in mind your drugs are not going to work for forever, so they will start to wear off. Usually between the 5 to 10 minute mark is when you're going to start to see things wearing off. If you're going to need to give another dose of a paralytic, you always give more of the sedative, because you don't want anyone who's going to be paralyzed without sedation. And again, if they are not fully paralyzed, they may try to tighten up some of those muscles in the neck and in the mouth, and they need to be loose in order to get that movement with the laryngoscope needed in order to be able to pass that tube there, whether using a glide scope or using other blades, whatever the case may be. And again, around the 5 to 10 minute mark is when you want to start to consider redosing. And it's kind of funny because depending on how many people you have around in the room, usually it's kind of a pretty chaotic event when you're doing intubation, at least in the ER, where it's more of an emergent sort of thing, as opposed to OR, where it's like most of that stuff's pretty well planned out. In the ER, a lot of times people will be focusing so much on getting the tube placed that in some cases it's been me that has to say the question of like, hey, it's been like 8 minutes. I'm starting to see the patient move their legs a little bit. Do we want to give more drug? And then like you'll see someone pop up and be like, oh yeah, we should definitely do that. Let's go ahead and do it. And again, time has a weird dilation sort of effect. It's almost like you're traveling close to the speed of light, where everything seems to slow down because you say, okay, give this 2 minutes before, the sedative 2 minutes before the paralytic. That 2 minutes will feel like 2 hours almost when you're in like an emergent sort of setting there. And you'll feel that too, like during your sims and whatnot, that you definitely get that time dilation effect there. So again, that's why clocks are very helpful, usually everywhere in those types of rooms, and being able to set timers for yourself can be really helpful as well. So again, when you're looking at your RSI meds, just remember that there's no perfect drug for every patient. You need to take it on a very case-by-case basis, which is why this is fertile ground for me to ask all kinds of like clinical vignette questions on the exam, right? Not just saying which of these things is a contraindication to succinylcholine. I can ask you like a case, right? So those are kind of questions I like to ask with this stuff here. Just focus on the history. If you're able to get it from the patient beforehand, that's great. If not, from the family. A lot of it has to do with physician or provider preference and comfort, and just the patient's presentation. Are they coming in after a car accident? Are they coming in after, for asthma or for a seizure? Things like that are things you always want to consider there. So anyway, any questions on that so far? You guys have been asking a lot of questions already, which I appreciate. I usually get a few murder-based questions, so I definitely don't mind answering those. I think succinylcholine is a little bit harder to detect because it gets broken down in the body, and it's just turned into choline and acetyl-CoA anyway. So it's hard to detect by the medical examiners and whatnot. Kidding. Actually, what's funny though is that I never knew this, but in the state of Florida, we have medical examiners. In other states, they may have just coroners. And to be a medical examiner, you have to be a physician. You have to go through the pathology residency, pathway and all that stuff. For a coroner, it's like an appointed position. Like you have coroners who are have no medical background whatsoever. So if I was going to murder someone, which I never would, it sounds like doing it in the place where a coroner works would be a lot easier because of the fact that they don't have as much knowledge and skill set as a medical examiner would. So it's something I never knew until I actually got to talk to a medical examiner. Anyway, so let's talk about some of our, I don't know that it would cover all of these, but we'll at least get started here talking about our ACLS meds. We'll see what we can get through. Questions on here. Anyway, murder is no laughing matter though. Don't murder people, please. Whatever you do. Anyway, now that I spit on my screen, oh well. So we have a whole list of drugs that we're going to be utilizing here. I guess I should probably, like, since this is all going to be on videotape, you could like use it at my court hearing later on. I do not advocate for murder. Okay. So whole host of meds we're going to be using during a cardiac arrest sort of event. Some of these are going to be sort of bread and butter meds you're going to use for a lot of those patients. Some of these are going to be more situational based. Some of it may be pretty apparent already just looking at something like, dextrose. When would you use that? Well, perhaps when their glucose is low, So some of that will be obvious, but we'll talk about these drugs specifically, when, how we use them, and whatnot. First things first, and this is something I didn't realize until I was actually out and like practicing when I got into my fellowship. I didn't realize like how you actually even get the drug out of the syringe here. A lot of these crash carts come with these they're called abject syringes, and so you'll open up the box, and first things first, like you may have to make sure, and you can always tell who's a newbie, and you may be asked to do this during like your rotations. You have to know which side of the box to open it from, and so you notice here it says pull to open here at the, or push and then pull to open. That's really important to open from the right side, because otherwise if you open it from the other side, the syringe and the drug won't actually come out, so you look kind of silly and people know it because the patient's like actively coding in front of you. So you want to make sure you're doing it right. So anyway, so it's going to come here in this barrel, and then it comes as the vial of the drug as well. So most of these are going to come like this: bicarb, dextrose, epi. They'll come in a very similar sort of packaging here. So it's important to know how to do this. So first off, what you need to do is to be able to pop off the yellow caps here. And again, this is just more so you don't look silly when you're doing this in real life. That's so funny, Jackson. I always do the same thing too. I'm always just like, boop, pop pop the two off of there. So you look really cool when you do that, but you have to pop the yellow caps off, and then you can take the vial here, place it into the syringe, and then you twist. And there's a little needle in there that's going to pierce this rubber stopper here, and then that way you can get the actual drug out. So this either has a needle on the end, or it has the lure lock connection, so you can have dual ability to connect here, but usually the lure lock is what we're using. So they'll unscrew that little yellow part, and then you can push the med into the patient once it's actually hooked up to them. And so it's a very easy, fast way to be able to give a dose. Now, this is usually for like adult patients, and where the whole vial is the dose for that patient. It's very standardized at ACLS. With PALS, it gets to be a little bit more complicated because everything is weight-based. So you can't necessarily count on using that whole vial. And in fact, when you have like a 10-kilo little kid coming in, or maybe even have like a 3-kilo infant that you're trying to dose, it can be much more hectic and challenging. And if you ever want to see a lot of freaked out people, take a coding infant into an adult ER facility, and you're going to see a lot of people that don't know what they're doing necessarily, especially with the drugs, because it can be very challenging from that. I'll touch on that just a little bit later here. Anyway, so you can just here, I can see how you do this. Remove the caps, twist it in, and then now you're ready to go. You're going to put it into connected to the patient, whatever line they may have, and then you're good to go, which is great. So I'm going to break this up into a couple different categories here. First, we're going to look at our meds we use for bradycardia. Obviously, anything we really consider less than 60 BPM, although we certainly know people may have resting BPMs less than that, but we'll consider this, if they are having a cardiac event related to bradycardia. Yeah, it's funny because I worked with Dr. Luton over at UF. Now it used to be Shands, but now it's UF Health in Jacksonville. So if you ever hear the Broslow-Luton tape, Dr. Luton was one of the pediatric docs that I worked with up there, which is kind of like a medical celebrity almost that you meet. I actually don't like the Broslow tape very much. It doesn't give you specifics in terms of like volumes to use, but I'll maybe touch on that a little bit later on. But anyway, so first off with epinephrine, this is kind of like your bread and butter medication used for pretty much just in general cardiac arrest. We're going to see that this is used usually every 3 to 5 minutes. I'll show you some of the algorithms here in just a little bit. But again, bread and butter medication here. What it does is act as your own natural epinephrine. It's an endogenous catecholamine, so it's going to be stimulating both alpha and your beta receptors, stimulating those in order to get increased heart rate, increased blood pressure, and then coronary perfusion is the other thing here. So when do we use this? Well, lots of indications, right? If we have patients with symptomatic bradycardia, meaning their heart rate is less than 60 and they're showing signs of poor perfusion, Maybe they have cold limbs. Maybe they're showing that they're not, being able to perfuse things like the CNS or the kidneys quite so well, things like that. Any kind of signs of poor perfusion with bradycardia, we can use epinephrine here. Cardiac arrest is going to be another big one. Again, you can see you can use it for VFib, VTAC, asystole, PEA. Any of those you're going to be using epi pretty consistently there. And then, for things like, anaphylaxis will probably be another big case where we're going to see epi being used most commonly. So, again, the dosing here, I'm only going to just kind of not expect you to memorize. I'm just kind of pointing out some of the things just so you have at least some exposure to it. You're going to have your whole ACLS class this summer where you're going to get much more familiar with this stuff and actually doing it, in person, hopefully. And then you'll get a better feel for it. But basically, you always want to be careful with epinephrine because there are different concentrations that are out there. And so it used to be, and you'll still see some old packaging that has this where it'll say, oh, it's epinephrine 1 to 10,000 or 1 to 1,000 solution. That led to a lot of errors because people would give the 1 to 10,000 solution when they meant to give the 1 to 1 and vice versa. And that could either lead to a tenfold overdose, which is not great when your coronary vessels explode basically, or if you're giving a tenfold underdose and then you're not really treating the patient very well. So you got to be careful in making sure that you're using the concentration that you want. Basically, the 1 to 10,000 solution is a 0.1 milligram per ml. Basically, it's 1 milligram in 10 mLs of drug, essentially. With the 1 to 1,000, it's 1 milligram of drug in 1 ml. So it's much more concentrated, 10 times more concentrated there. Typically, you're going to use the more concentrated form, either if you're using the drug intratracheally or if you're going to be using it as like a sub-Q IM sort of dose there. So like for epinephrine, for anaphylaxis, you'd be using IM epinephrine, usually at this higher concentration. Anyway, point being is that if you have someone who is experiencing bradycardia, if they're in cardiac arrest, IV-IO, we can administer the epinephrine. Note here that for patients who maybe don't have IV access, maybe you don't have an IO available, you can actually do endotracheal dosing, which is kind of interesting. There is a mnemonic you can use for drugs that you can give endotracheally if you had no IV access whatsoever. It used to be naval, but now it's lean. But basically it's naloxone, atropine. We used to use Valium or diazepam, but that's we don't really use that during codes much anymore. And then epinephrine and lidocaine. Or if you're using the lean, it's lidocaine, epinephrine, atropine, naloxone. Those are 4 drugs you can use. Kind of interesting, but remember, because since if you give it IV, it's 100% bioavailable. If you're giving the endotracheal tube, it's going to be less bioavailable, so you have to give a bigger dose here. So you notice here's about a tenfold bigger dosage you're having to administer there. So, up to a max like 2.5 milligrams versus 1 for IV. But again, I'm not going to ask you specific dosing on the test, just trying to give you some context here for how we use this stuff. And again, there's been cases where someone meant to give the 1 to 10,000 solution and they accidentally gave the 1 to 1,000. If you use the same volume, you're obviously getting a tenfold overdose, and that's led to cerebrovascular accidents, hemorrhage, etc. In the code cart, you're actually going to find that there is usually like a big vial of 30 mLs of the 1 to 1,000 solution, grams of epinephrine. And then there are the Bristol-Jets or the pre-filled syringes that have just 1 milligram. It's that 1 to 10,000 solution. I'll never forget one time where we were in the ER and there's a patient who we needed to set up an epi drip for, an epinephrine drip in order to maintain their blood pressure. And this was 2 nurses who were, I don't remember what I was doing at the time. I was probably doing like another medication kind of nearby or something. But I remember these 2 nurses, one was a junior, one's a senior nurse. Senior's trying to show the junior one the ropes. And they need to make an epi drip. And so the senior nurse was like, okay, take that whole epinephrine and just put it into a bag of saline, and then that's how we make an epi drip. And so the nurse, junior one says, oh, the whole thing of epinephrine. And then senior one is looking at the patient and said, yeah, the whole thing. The senior nurse had meant the pre-filled syringe of 1 milligram of epinephrine. The junior nurse meant the 30 milligram vial. So that was like a 30-fold difference in concentration there they'd be getting. And fortunately, it was caught before it got hung on the patient. But it was one of those things that was a really close call. I think the patient ended up dying anyway, so it probably didn't matter that much in the long run. But again, in these high kind of high acuity settings fast-paced environments, it's very important to make sure that you're very clear and descriptive about what you're talking about. Not just say, hey, this one, that patient over in that room, like say specifically like what you're talking about, because that'll get you out of a lot of trouble. As I mentioned, ET tube dosing is very uncommon nowadays, I think mostly because things like IOs are much more available, and I think many more people are comfortable setting those up. You know, it's not uncommon that you would have a patient coming in with an IO via EMS, just because if they couldn't get an IV started, then they got to do something to start running meds, so they'll do that. So it's certainly not uncommon. You'll see that. I don't know that I've ever personally seen ET tube dosing of anything, but it's still listed, still available if you needed to do that. Usually it's about 2 to 2.5 times the normal dose that you're going to be seeing used there, and there's the 4 that you can use potentially. And again, just something just as a point of info that you could do it, but most of the time it's not going to be available. Maybe if you're like working somewhere outside of the country, and they had less access to things like IOs, maybe that's done more commonly there. But so next up we have atropine, which we've talked about briefly before. This is, again, a muscarinic antagonist. Its primary use is going to be for symptomatic bradycardia to try to bring the heart rate back up, especially if it's related to things like AV block, vagal-mediated bradycardia. This is where it's going to be used most frequently. It used to be used as cardiac arrest, or for cardiac arrest, but it's been removed from the guidelines for that. So if you ever see some old school providers, they may still want to use it during cardiac arrest, but it's not really indicated anymore via the ACLS guidelines now. Really just used for bradycardia to try to pick up that heart rate to hopefully get perfusion better. Yeah, so not done too frequently there, and you can use it intratracheally if needed. So we kind of talked about that previously when getting into the pre-treatment, you know, in case you need it for RSI or something like that. Now for tachycardia, here is a different thing we can do here. I think we talked about adenosine briefly when we were talking about it back in the antiarrhythmic section here, but this is another really fun drug to give. I'm sure some of my ER people or EMS people have used it, can attest to how kind of exciting of a drug it is to use. But basically, this is really good for supraventricular tachycardia, like PSVT, is where you're going to be primarily using this. And basically, it causes, it's almost like flipping the on-off switch on your modem or something like that, to where you're basically trying to reset the heart, hopefully getting it back into a normal sinus rhythm here. It causes like a total AV nodal conduction block, and then will kind of interrupt any of those reentrant circuits. They're causing that PSVT. They're kind of originating in the atria. You know, this is one of those things where you had the patient on the continuous EKG. You'll slam the first dose of the drug. Remember, it has a short half-life, less than 10 seconds. And so you have to make sure you're giving it very quickly. Usually we'll have that 3-way stopcock set up to where we have the drug on one end. We'll have the saline flush on the other end, usually about 10 mLs of normal saline. And then we'll have the third end hooked up to the patient. Another way to look really silly in the middle of a hectic situation like that is to not know how to work the stopcock. Remember, the handle on it is going to point, whenever it's pointing, that's the direction of no flow. So you want to make sure it's pointing away from all three sides, so that way you can slam the drug in, slam the saline afterwards, and get it into the patient. I think I have a picture of it here. All right. So typically you'd have like your drug on this end, you'd have the saline flush on this end, and then this would go to the patient. In this case here, this would be off, right? So this would, you wouldn't be able to push your med in, and you'd look kind of silly because they'd say, well, push the med, and you're like, I can't, it's not going, because it's pointing in the wrong direction. So if you pointed this in the opposite direction, over this direction here, everything can flow perfectly fine there. So just one thing to keep yourself from looking silly. A lot of times that first dose won't work, and that's because it was not given quickly enough to actually get to the heart. So that's why people usually see better response on the second dose, and they give a double amount basically. But yeah, so you should see basically the heart completely stop on the EKG, and hopefully, you know, you have that kind of that really pregnant breath that happens there. Everyone's like, and then you can you'll see the heart go back into either back into PSVT, or it'll go back into normal sinus rhythm, which is obviously is the goal there. Yeah, so, and again, these are like tips or stuff that maybe I've not done, but I've seen done, or some of these are stupid things that I've done. Because again, until you do it like the first time, it's kind of this weird ethereal sort of ideas in your head. But putting it into practice really will drive a lot of this home. So again, I encourage all of you to be as involved as you can on your rotations, especially in the ER, to do as much as you can, because it's the time to screw up and make mistakes is when you're students, right? Because you're not as responsible as you're going to be when you actually get out there and are practicing. Because people still look to you like you know what you're doing. You'll still have nurses who will come up and ask you questions, and they'll take what you say as the gospel truth until proven otherwise. I don't know if I ever told you guys a story when I was on rotations in the ICU. I was a student still. And basically my preceptor got to a point where they were comfortable with me going on rounds. I may not know all the answers, but I can at least, look stuff up and be able to respond to questions and whatnot. But yeah, I had a physician who was a resident came up, asked me, hey, what's the dosing for enoxaparin for this patient here? And I was like, oh, I think it's this. And they just wrote it down and put it in the order. And I was like, holy cow, like I'm not even a pharmacist, and they're asking me questions like this, and they're expecting me to know what I'm talking about. I looked it up afterwards and made sure that I was right, but I had to be prepared to go back with my tail between my legs and correct myself if need be. But just be careful, because people will certainly think you have a certain position of authority, even if you may feel like you have zero authority, just because you have that white coat on and name badge, and people think you know what you're doing. Anyway, I'll probably hit amiodarone here before we go. I may have finished these two here. Anyway, so next up we have amiodarone. This is going to be, like, again, another kind of bread and butter med for patients who have any sort of like tachyarrhythmia that's not like a PSVT, because if you recall, amio is good to work both in the atrial and ventricular arrhythmias. There's a class 3 antiarrhythmic there. Usually we can use it as a backup to adenosine. We'll use it for any kind of wide complex tachycardias, and then someone who's in VFib or VTAC, this is the drug to go with, right? Now, again, if you're having a patient who is in cardiac arrest and VFib or VTAC, then you also need to consider doing electricity, right? So defibrillating the patient. But when you're switching to medication therapy, this will be the one to go with. This is something where we typically will give like a bolus dose and then can follow it up with a continuous infusion afterwards in order to make sure they get a good, because remember, amio has a really long half-life. So that's why we give a loading dose up front, and then we can do a continuous drip afterwards to kind of keep them at a sort of steady state there. If they still have a perfusing rhythm, you want to be giving it slowly, because it can cause hypotension, bradycardia. But if they are actually like basically dead in front of you, you can give it IV push, and that's fine. Hopefully the chest compressions are going to be circulating that around. But remember, if it is effective, you got to follow it up with a drip. So one thing to note with that one there. Lidocaine used to be sort of the go-to ventricular arrhythmia or ventricular antiarrhythmic. However, it's been largely supplanted by amiodarone, just due to its kind of broad nature, capability to treat all kinds of different arrhythmias here. So you still see lidocaine being used occasionally. You may see this being used more so for cases like MI, because if you recall, has a little bit better activity on areas of cardiac tissue with ischemia. That may be one thing there, or if amiodarone is not available, you could use this as a backup in those cases there. Just be careful, because this would be one you'd also want to do a bolus followed by a drip. And if they have hepatic impairment, you do have to decrease your dose by about half. Otherwise, you can see things like that neurotoxicity that could be apparent. So if the patient was like complaining about a metallic taste in their mouth, or they developed a seizure, it could be related to the lidocaine there. Again, do a loading dose, get them up to steady state, followed up by the infusion there. And this is another one you could do endotracheal dosing if you needed to. Just FYI. And then in terms of other antiarrhythmics, magnesium is sort of like your go-to for torsades. That's an easy board style question for the pants. That's an easy pimping question from your preceptors. You got to know magnesium. It's treatment of choice for torsades. And again, it's pretty apparent when you're looking at it on the strip to see those kind of twisting of the points that happen there. But again, be aware that this could be something you see beforehand by looking at the EKG. See a prolonged QTC. And I actually had a case of this not too recently where not too long ago. I think it was, I'm trying to remember, I had so many calls that night. They kind of run together when you're being woken up at 1, 2, and 3 o'clock in the morning. But one of them did have a significantly long QTC, and I think it was up in like 630s or something like that. If you think about it, normal is 440s. I think the doc went ahead and gave a preemptive dose of magnesium of 2 grams. Again, I don't know how well it works as a preventative, but it was certainly something to where that was a big concern. And if they did go into torsades, that would be the automatic one you'd want to give at that point there. Just be aware, it can cause hypotension if you're giving it too quickly, so you may want to give some fluids along with that to make sure it doesn't drop their pressure too much when you're giving that quickly. Okay, so that's most of it for the antiarrhythmic sections. I'll get into the rest of this next time, and then we can finish up and then move on to our next section when we meet tomorrow at our destined time of 2:30. Do you guys have any questions? It was actually perfect to end right at 2:10, so. You guys have been awesome today. If you don't have any questions, you're free to go. Thank you for joining me. All 2/3 of the class of you. 5 likes. That's fantastic. I like getting likes. And thank you. A wonderful day. I'll see y'all tomorrow afternoon. Make sure to keep your energy up. I'm gonna make sure you are gonna be awake and with it and aware of what's going on tomorrow. Otherwise, you know, that Friday weekend time frame is just calling to you. But be present, be here. This is gonna be an awesome lecture. I hope. Maybe not. It could be terrible. So we'll see. All right. I don't see any questions here, so you guys have a great one. I'll see y'all later.